classification, and now we move towards that what else you can do with your patient. Obviously you need to do the ECG in your patient after all this clinical examination and all these things. Obviously in stable ischemic heart disease you won't get any remarkable clinical examination with your patient. So you would get done the ECG, and you may appreciate the Q waves and anything like most of the time our patients of the stable ischemic heart disease have a normal ECGs, normal sort of ECGs, but excuse me, if he or she has a history of like old MIs, so they may have Qs and or any insignificant things. Or if your patient is coming from this stable sort of chest pain, but he or she has a depressions or anything which is labeling patient as a patient of the ACS, then you need to rule out your patient, that is your patient of unstable or non-ST elevation or sort of the acute coronary syndrome. Either he or she has acute coronary syndrome or stable ischemic heart disease, because it is actually necessary to differentiate your patient in the triage that he or she is a patient or he or she is suffering from the stable sort of ischemic heart disease or unstable. Now how we diagnosed it, if you want to evaluate your patient in the stable ischemic heart disease, so what the modalities you have actually, then you obviously first of all you need to rule out that is your patient is low risk patient, like their pretest probability is low or high. If it is low, then you do not need to do anything. Okay, we will discuss here, I think we have discussed the pretest probability in our last lectures. So if low, you do not have to do anything. Okay, but if it is intermediate, so this is the actually gray zone where we need to do the work. We need to evaluate our patients because they are neither in the low risk nor high risk, and those patients who are actually high risk, then directly we will go for the invasive management, invasive like the coronary angiography or all these sort of things, because of our patient lies in the group of high risk and we don't take chance over their lives. So but the intermediate is the gray zone, neither they are low risk nor they are high risk. So this is actually the area where we need to work, and we need to evaluate our patients with non-invasive diagnostic testing. Okay, so first of all we have a what modalities we have stress exercise, stress exercise ECG, okay, and ETT. Okay, stress ECG, what we do we do actually that we instruct our patient to run on the treadmill, and we trace the ECGs at the different match score. In stress testing, what is the important thing, that your patient should be on the age predicted maximal heart rate. It should be more than 80% of age predicted maximal heart rate. How would you calculate the age predicted maximal heart rate? You would just minus the your age of, if you would minus the age from 220, you would get the age predicted maximal heart rate, and you need to achieve your patient has to achieve the 85% of the maximal age predicted maximal heart rate to for the diagnose your patient with stable ischemic heart disease, or actually for the more labeling it your non-invasive testing as a more specific. In stress testing, your patient should achieve 80% of their age predicted maximal heart rate. So in the exercise ECG, there are sort of some limitations we have, like LBB, hypertrophic, LVH like, okay, previous ST depressions, any pacing rhythm, because in pacing rhythm again you would get LBB, and what else are there, ditch, patient is on ditch therapy. So these are sort of some limitations of the study, but these are not the contraindication, but these are the limitations to check the ischemia or check the ST deviation, because in ETT you actually look what you are looking for, the ST deviation. If in these ECGs patients have already baseline ECG, if patients have on their ST deviations on their baseline ECG because of LBB and all these things, then you want diagnosed your patient with stable ischemic heart disease. You cannot look for the ST deviation in your patients with the ETT. So that's why these are actually limitations. But if you are going for the ETT for any other reasons, like for suppose chronotropic response index or CRI or these sort of things, then you can go for the ETT. If you are going for the functional class, you can go for the ECG. But for the ischemia, for looking for the ST deviations, you cannot go for the ECG in the stable ischemic heart disease in these limitations, because you cannot comment over it. But there are absolute contraindication of the ETT. So those were the limitations of the study in this limitation of the ETT in ischemia. But there are absolute contraindication of the ETT in any sort of condition like ACS, acute heart failure, or acute sort of like tachyarrhythmia, if patient is handicapped, can't run, your patient is so fragile, so he can't achieve the METs. So these are the absolute contraindication. You cannot go the exercise testing in these sort of the patients, because their conditions get worse. Okay. Now second modality we have echocardiography. Okay, in echocardiography we have a stress echo, like stress, you can give the stress by exercise or you can give the stress by dobutamine. Okay, in dobutamine stress echo, you actually differentiate your patient with hibernating myocardium, ischemic cardiomyopathy or non-ischemic cardiomyopathy. What three things you have. And you can actually tell in ECG, ETT, you cannot tell the area, affected area of your patient, but with the dobutamine stress echo, you have a rough idea of area involved with the area involved in stable ischemic heart disease, or which area or which territory is actually involved. So in low dose dobutamine, in actually an SCAR or ischemic cardiomyopathy, we have actually, we give in stress echo cardiography, what we do, we actually start giving the dobutamine from the low dose, and we will go and we will go towards the higher dose. So we start from 5 mics, and then every 2 to 3 minutes we increase the dose by 5 mics. Like initially we start from the 5, and then we will give 10, and then 15, and then 20, and then 25 to 30. So what we will see, that we will see the response at the low dose and high dose. Okay, in the scar tissue you will not see any response at the low dose and the high dose, no response. So then you will get that there is a stenosis, and this is infarction probably, because this is a scar which won't give response to the dobutamine either on low or high. So now comes the hibernation. Okay, in stress echo you will check for the bimodal response, low and the high. So in hibernation, on low dose contraction will increase, but on high dose contraction will decrease. Then you will get it that your patient is in hibernation, your patient has ischemia which can be corrected. Okay, so yes, there is a stenosis, coronary stenosis, and this can be corrected by any intervention or anything. The last but not the least, we have here is the non-ischemic cardiomyopathy. In non-ischemic cardiomyopathy, what it does actually, it increases on both. It increases on low as well as on the high. So you would get that this patient has a non-ischemic cardiomyopathy, most of the time non-ischemic cardiomyopathy, and he or she has probably no coronary stenosis, because it is increasing on the low dose as well as on the high dose. But if it is not increasing on the low dose or the high dose, it is ischemic cardiomyopathy and has a probably fixed sort of perfusion, a sort of the fixed defects. But if your patient has like the tissue of your patient, cardiac tissue of your patient is in hibernation, then on the low dose it would increase, and then on high dose it would decrease. So what are the limitations of this study? Again, as in the stress ECG, we had some sort of limitations. Here again we have some sort of limitations here, like hypertensive response, because if you will give your patient through the dobutamine, then your patient might go into the hypertensive crisis. And AR and any active ACAs or sort of going disease, pre-existing wall motion abnormalities old. So you cannot go like stress echo in these patients. Okay, and these are the limitations, and the contraindications remain same if your patient has active tachyarrhythmias, and if your patient is sort of any cardiogenic shock or any active going critical disease, or if your patient has acute coronary syndrome, then you will not like go for the stress echocardiography in your patient. The other modalities we have obviously SPECT. Now we have the nuclear imaging. In the nuclear imaging we have two things. One is a SPECT, and in SPECT we have two things: thallium and technetium. We use these two things to do the SPECT test in our patients. And other thing, we have a PET scan. So which one is the better? This is easily and freely available, and this is cost effective. It is actually costly procedure, and it requires contrast to be infused in your patient, like 15 to 16 cc per image. So this is sort of this is not for the contrast, but in PET scan, the actually chemical which you use is 18 labeled deoxyglucose to do the PET scan in your patients. Or the limitations are, again, what are the limitations of your SPECT test? SPECT test limitations are obesity, because in obesity you will get the artifacts, you will get the breast shadows and all these things. And balanced 3 vessel disease, in balanced 3 vessel disease you will not get the sufficient result to prove anything, and your results would be equivocal. And the third one, you have like LBB. In LBB again you will not get the good results of this SPECT test. So in which cases we actually should use the PET? PET actually tells the what? SPECT tells us the area which are in hibernation or fixed perfusion defects, but PET scan tells us about the coronary flow as well. It actually tells us about the coronary flow, so we can actually assess the coronary flow in the PET scans. So what else we have? We have a routine echocardiography. Every patient of a stable ischemic heart disease should go for should go for echocardiography, resting transthoracic echocardiography to rule out other diseases and old MIs and hypertrophic cardiomyopathy, valvular causes like ACE and anything. So you need to go for the echocardiography in all your patients of stable ischemic heart disease. What else we have is MRI. MRI is costly, so it is very less likely that we get done the MRI in our patients. Yet yes, but you can go for the MRI. And next thing is EBCT, electron beam computed tomography. So it is especially used for the calcium scoring. Okay, calcium scoring, and this is actually get done in the low risk patients to check the calcium scoring, and it tells us the future risk for the how much your patient have risk or to develop the coronary artery disease in the future. So because it tells us the calcium scoring. So what else we have is multi-detector CT scan, CT multi-detector CT computer tomography, multi-detector computer tomography or CT. So it if you have a 64 slices multi-detector CT scan, then you have 84% specificity and 97% sensitivity. So it is actually good modality to use this non-invasive modality in your patients with the stable ischemic heart disease, and it has a 99% negative predictive value. If your patient it means that if your patient has nothing on the CT scan of like 64 slices multi-detector CT scan, then probably your patient should not would not have anything. But the drawbacks of multi-detector CT scan is that you cannot look for stunt restenosis. You cannot look for the in CT multi-detector CT scan you cannot look for the stunt restenosis, and about the conditions of the stents, the plaque morphology, that how the plaque is actually, is it unstable or stable, what about the struts of the stents, what about the surface of the plaque, what is about the capsule of the plaque. You cannot comment over this. Yes, you can comment, but you cannot sure about all these things. So you cannot actually look inside the coronaries, but you can actually see the coronary network, or you just look for the coronaries in the multi-detector CT scan. What else you have now? These all were the non-invasive investigations. Now we have invasive investigations. In invasive investigation we have a coronary angiography, IVS or OCT, optical coherence tomography, and last one we have is fractional measurements, fractional flow measurements. These three are what? Invasive. These three are invasive modalities to diagnose the stable ischemic heart disease. Obviously, in which patients you can go for the coronary angiography, it is clearly written everywhere, and in our guidelines AHA and ACC told us that in the patients who are the 3 and 4 CCS symptoms, you can go straightforwardly. It is class 1 to go for the coronary angiography. What else? If your patient has a presenting with the cardiac arrest, you can go, you have to look for the coronaries in these patients, and symptoms of the congestive heart failure with no obvious reason. Obviously you need to rule out the ischemia first, and if your patient has high risk features on non-invasive investigations which we have discussed earlier, all these investigation, if you get high risk features or non-invasive investigation, you need to go for the coronary angiography. These are actually class 1. We have a class 2 as well, like if your patient has a low EF less than 50% with no obvious cause of the angina or low EF, then if your patient has severe angina with preserved ventricular function and risk non-invasive testing, or if your patient has a suspicious of left main plus 3VD, like you are getting AVR elevation plus sort of ST depression, but your patient has a sort of stable sort of pain or stable sort of complaint, then you can go for the coronary angiography. It is class 2A in your patient. So we will discuss all these things in our the guidelines of this stable ischemic heart disease. Right now you just understand that we have an invasive modality which is actually very important, is coronary angiography, which is the important in our cardiology. Okay, so you this is actually double-sided sword. We need to know about that in which patients we have to go for the coronary angiography, and in which patients we do not use these modality because it has risk factors. It has its risk factors. Now we come to the IVS and OCT. These both are again invasive, so you cannot use these both modalities like routinely. Initially you have to go for the coronary angiography if you because for IVS and OCT you need an access. So in IVS what you are doing, you are doing the ultrasound, you are doing intracoronary ultrasound. Okay, so you need to look for the morphology of the plaque. Actually in this you actually look for the morphology of the plaque and artery size, how the artery is size, and the stenosis, luminal stenosis. These all things you can easily appreciate through intracoronary ultrasound. But if you actually want to look for the if you are looking for the better resolution and you want to actually accurately see and calculate the morphology and artery stenosis and luminal stenosis and the plaque and the morphology of the plaque, then OCT is the better one. But the drawback of the OCT is with that you need to use the contrast in your patients with the OCT, so it is relative contraindicated in your chronic kidney heart disease. So chronic kidney disease. Okay, I have become insane now. So IVS and the OCT. Last but not the least, we have a fractional flow reserve. We will discuss it and then I will leave you at your own. Sorry to take your too much time because it is actually a lengthy topic. We need to understand it. It is actually difficult to understand the stable ischemic heart disease. So we have two things here. One is the FFR. FFR is very easy. It is actually the direct measurement of fractional flow in your coronaries. What you do the catheter of the FFR, and here is the for suppose here is a plaque. What you will do, you will just measure after giving the maximal dilatation, vasodilatation. After giving the maximal vasodilatation, you will just calculate the pressure here, like proximal and distal. Then you will take the ratio distal to proximal. If it is equal to 0.7 to 0.8, it means it is a significant stenosis and you need to go for the cath in those patients. So the trial which supports it, and that is the only trial which supports the coronary angiography in stable ischemic heart disease. But it tells us that you if your patient has been done, if your patient has gone for the coronary angiography, now he or she has a plaque. So before going for angioplasty, you need to go for the FFR. So if you will go for the FFR and you will get the FFR of 0.7 to 0.8, okay, less than less than 0.7 to 0.8, less than 0.7 to 0.8, then it means your patient has a significant stenosis, and if you will go PCI in these patients, then you will get the mortality benefit. So FAME trial told us that if FFR guided PCI should be done in the stable ischemic heart disease after coronary angiography, so it actually benefits, it gives benefit to the to our patients. Now the important thing, this was the FFR. Now we need to discuss the CFR, coronary flow reserve. Actually, this is the invasive functional measurements. It has actually, we have a lot of modalities to calculate the fractional flow reserves and the fractional measurement. So which we have discussed previously. It was fractional flow, it was FFR. Now we will discuss CFR. What is the CFR? CFR is actually when you will just after giving nitrates, on adenosine, this nitrate should be given intracoronary. After giving intracoronary nitrates, you will check the flow, the velocity across the plaque on adenosine. What is the coronary? This is a CFR. This is CFR. Actually, you will just check the flow after giving the intracoronary nitrates on adenosine. If this velocity will not increase more than 2 folds, it means your patient has severe coronary flow defect. You need to do the intervention on this patient, and it means your plaque is physiologically significant, has a significant stenosis. You need to open it up. If your patient has intracoronary, after giving the intracoronary nitrates on adenosine, if you check the velocity of the blood flow across this plaque, and if it would not increase on adenosine more than 2-fold, it means your patient has significant physiological defect and you need to correct it on cath, I mean PCI. I hope that we will do it better, and we will discuss inshallah therapy and all these things, all the drugs which we use in stable ischemic heart disease one by one. Then and last we will discuss the interventional strategies in the stable ischemic heart disease, that which patients we should go for the cath, and in which patients which patient actually need cabbage and all these things. So we will discuss it in our next lecture. Thank you.